Hello there, it's Dr. Shelley, and like I said, we are looking at endocrine disorders. So today, behind me on my magic board, I have Cushing's disease. Now you may remember that I just did a video the other day on Addisons, and please keep in mind that we have handouts that go with all of these diseases, right? So if you notice that HETV is based on like this playlist, like you have to go to the playlist, and then you have all your subjects for everything, then you probably also know that we always have handouts for every lecture that we do. So every video that we do, there is a massive handout. You know the Oh My God packet is the key to everything. It has diets, basic care and comfort, positioning, prioritization, delegation, labs. It has your quickie in here about who to see first. It's got your pharmacology quickie. It's got all your tips on how to study. You know that already. I know you know. All right, so just remember that we are not in a vacuum. I'm not just yapping without you having somewhere to take notes. So the handout for this video is endocrine, because Cushing's and Addisons are endocrine disorders. And so I want to make sure that you see in this actual packet what we already did. We did a video on Addisons, right? So we covered every single thing on here. I left that part of the board up so that we can compare and contrast, just in case you didn't see that video. Today, however, we are doing Cushing's. And so you see the Cushing syndrome and you see the different problems with homeboy and his little issues, and we're going to talk about all that stuff, honey. So a lot of what I'm saying, if you had the packets, you wouldn't have to write so much. You could pretty much like highlight things. You know how that is. So let's get started. So what I have here is and I'm going to start talking about the whole Cushing's issue. Like I said, last time we did this, I talked about the Addison's issue. And I want you to know that I'm going to review it a little bit, but you kind of got to go to the Addison's video to get all the juicy, itty bitty juicy stuff going on. Now, so here we have Cushing's. We know for a fact that Cushing's is an endocrine disorder that has to do with steroids, right? I mean, that's common sense. Everybody kind of knows that. So what I tell you about endocrine is that there's like 6 major categories of endocrine on the NCLEX or HESI exam. There's your hyperthyroid, hypothyroid. There's SIADH, there's diabetes insipidus. There's Addison's, and then there's Cushing's. So today we have the two, Addison's and Cushing's. Again, I did Addison's. This is a quick review of it, but I'm really about Cushing's today, okay? So let's get started. Here you can see Cushing's syndrome. There's a Cushing's disease and a syndrome. We're covering both, but just call it Cushing's, okay? And then you can see that either it's extrinsic, which means that we gave you the steroids and it's probably for a chronic, long-term, maybe even significant dosages of steroids. These patients have Cushing's syndrome because they are getting these steroids probably over a long span of time for a lot of chronic diseases. Maybe it's Crohn's. These are autoimmune diseases typically, but not exclusively, like Crohn's or ulcerative colitis or multiple sclerosis, myasthenia gravis. Maybe it's the issue of Guillain-Barré. It's some type of inflammatory process, and they get frequent episodes where they have to have a bout of steroids, okay? So just think of that, lupus, whatever. That's extrinsic causes on the outside. I gave it to you. It wasn't something inside of you. Another reason for a patient to have Cushing's could be that they have a tumor on the adrenals. And that tumor on the adrenals could be an adrenal adenoma or something we're going to go into detail about, which is a Pheochromocytoma. Pheochromocytoma. Okay, good. That's down here as well. Pheochromo. Now, you're the bomb.com. You know I said pituitary adenoma or pheochromocytoma. And anything ending in oma is a tumor. Not necessarily cancer, but for sure a tumor. So adenoma, pheochromocytoma, oma means tumor. Something else I teach you about tumors is that a tumor on a body part sometimes gives you too much of what that body part was supposed to give you. So if it's a pituitary tumor, it might give you too much of whatever that pituitary was supposed to produce or secrete. Hope that helps. All right, now, it could also be any kind of tumor on the adrenals. Well, the tumor on the adrenals is a pheochromocytoma, right? But it could also be a tumor, and I definitely want you to see this, a tumor on the pituitary, right? So it doesn't have to be on the adrenals. It could be a tumor on the pituitary. Now, a tumor on the adrenals, pheochromocytoma or adenoma, is going to produce too much of what the adrenals produce. A tumor on the pituitary is going to produce too much of what the pituitary produces. That's the bottom line, okay? I hope you got that. It's a little confusing. But here we go. So let's get started because we love comparing and contrasting. When you take diseases that are very much alike and you see them compared and contrasted on YouTube, remember those are probably going to be case studies. So yeah, case study maybe, maybe, possibly, could be. All right, so let's look at this. In order to understand Cushing's syndrome or disease, you have to understand steroids, right? And in order to understand steroids, you've got to understand when does the body put out massive amounts of steroids or just simple amount of steroids. So in our bodies regularly, no stress, no nothing, we put out cortisol around 5 or 6 in the morning, right before we get out of bed. And the purpose of the cortisol to be produced that early in the morning is to make sure that it stimulates a high blood sugar so that you don't have to eat the minute you wake up. So cortisol in normal people secreted, increased in the morning, early morning, 5, 6 a.m. Part of the circadian rhythm is there so that we don't have to eat the minute we wake up. It keeps our blood sugar stable because we know that cortisol increases blood sugar. Cortisol in the morning, 5 or so a.m., is also there so that when we get out of the bed, we don't faint or fall out, because while we were in bed sleeping, our blood pressure is nice and low. And when we get out of bed, the cortisol production in the morning increases the blood pressure to the point where I don't have to worry about getting out of bed and my blood pressure is so low that I feel dizzy and I faint or fall. I hope that makes sense. That's with normal folks every day. That's why night shift is so difficult on the human body. And that's why night shift nurses gain a lot of weight, because the whole cortisol production never goes down. It just constantly stays up, and you get the high blood sugar, high blood pressure, high sodium and water retention, high weight gain, average of 10 to 20 pounds that first year working night shift. So I tell nurses all the time, don't stay on nights too long. Don't do night days too long. Nights, straight nights is better than night day rotation, but you get my meaning. Now let's kick it up a notch. Let's say that the patient is stressed. The stressed patient, the stress response is going to give us a sympathetic nervous system involvement where you go and kick in to a fight or flight type of situation. In other words, the sympathetic nervous system prepares the human body to get ready to kick ass or run away from somebody kicking your ass. If you look at the Addisons tape, her name was Debbie Jackson from Mississippi. Used to be kicking my ass every Friday, 6th grade. So if you're gonna fight or you're gonna flight, like run away from the harm, your body needs a lot of energy in the form of sugar. Your body needs to support you racing as fast as you can. So your blood pressure and your pulse have got to be able to give you more blood flow to the area. In order to do that, chemicals called catecholamines must be produced so that you can vasoconstrict blood flow in the periphery of your body and centralize that blood flow or shunt it to your brain and your heart so you can think. Also shunt it to your muscles so they can support you running as fast as you can. So there's a little bit of vasoconstriction going on. That vasoconstriction, again, is in the parts of the body that you do not need during this fight or flight situation. It even shunts blood away from the digestive system. The whole thing. You don't need to digest anything if a bear is chasing you. Okay, you better hope you live through that. So this whole stress response includes vasoconstriction, where we shut down areas of the body that don't need blood flow and make sure that we push the blood flow to the heart and the brain and the muscles that need it. And cortisol, production of cortisol, to make sure that we get that blood sugar up and it's like high enough to give us lots of energy. And our blood pressure and our pulse went up when you did the vasoconstriction, but it also goes up with cortisol. So cortisol increases blood sugar, blood pressure, sodium, and water retention. Now, remember that along with the effects of cortisol, the high blood sugar, the high blood pressure, the sodium and water retention, along with those effects comes a really big deal thing, which is decreased immune response. Let's see what happens. This patient either has too much cortisol from the steroids we're giving them, either PO or IV or whatever, too much, maybe an inhaler, Pulmicort or something like that for asthma, or maybe you have a COPD inhaler that includes steroids, whatever. So either we're giving you the steroids and this is causing a little bit of a problem in the human body because you've been on it chronically, okay? And maybe with such high doses and long-term use, you're starting to look like a Cushing syndrome patient. Maybe it's the fact that you have that tumor on the adrenals. And remember what the adrenals do. The adrenals produce adrenaline, which is epinephrine and norepinephrine. And this adrenals tumor that would produce adrenaline produces the catecholamines of epinephrine and norepi, and now the pulse and the blood pressure are high. So that could be the problem. And if that tumor on the adrenals is the problem, then you have a patient with a Pheochromocytoma. If, on the other hand, the cause of the Cushing's disease is a tumor on the pituitary, well, the pituitary puts out adrenal corticotrophic hormone, which stimulates the adrenals to put out cortisol and the catecholamines of epi and norepi. And there we are again with the high blood pressure, high blood sugar. You know, you get it. So watch this. We have a bounding, rapid pulse, tachycardic, because again, the effects of adrenaline and the effects of cortisol. The bounding pulse is what you see anytime you have fluid retention. Cortisol made you retain salt and water. So there we are with a bounding pulse. If you had dehydration like Addisons, the pulse would be weak and thready, okay? Now let's move on. Here you have a high blood pressure, a high blood sugar, a high ACTH, high sodium, which is the whole sodium and fluid retention, causing edema. So you really got to watch this patient's skin. And because sodium is the opposite of potassium, if the sodium is high, then the potassium is low. And you know why the sodium is high, because I said you have a sodium retention. Now watch this. Addisons is just the opposite. There is a decreased ACTH, which means there's a decreased blood pressure, blood sugar, because the cortisol isn't even there. And cortisol is the cause of all this nonsense, right? So if you don't have cortisol, you don't have blood pressure and blood sugar, you don't have blood pressure and blood sugar. Your patient has a decreased sodium because the salt left with the water, and they're very dehydrated, right? So again, weak and thready versus bounding. The only thing these two diseases share is tachycardia. So tachycardia, tachycardia. Low blood pressure, high blood pressure, low blood sugar, high blood sugar, low ACTH, high ACTH, low sodium, high potassium, low potassium, dehydration, fluid retention, weight loss, weight gain. Do you see? It's all the effects or lack of the effect of cortisol and those catecholamines of norepi and epi. Okay. Now, those things were exact opposites. Let's dive a little deeper into Cushing's and find out what else we can find. We have something called a buffalo hump in the Cushing's patient. That means that this patient has fat pads on their scapula or on their back. These fat pads literally are fat pads, and they kind of are very obvious. And they also have that moon face for the same reason. They have the fat and they have the swelling, the edematous kind of puffy face, really round, really moon face. This is all part of Cushing's. The patient has truncal obesity. So I wanted to show you this picture because it's so clear in the packet, this truncal obesity, also called central obesity, okay? So big old round tummy. I mean, it's quite serious, okay? Big, huge tummy, sometimes called, again, central obesity or truncal obesity. That's all part of it. We already said the cause could be extrinsic, where I personally, as a provider, gave you long-term high doses of steroids. That could be the problem. We know that this patient's going to need a special kind of diet based on what's happening with them. I'm sure you could have figured out by now this patient needs a low sodium, probably doesn't need to push fluids, right? Maybe a little bit of less fluids, although I don't really want to say fluid restriction because that is rare, but we're not encouraging fluids, that's for sure. High protein, high potassium, more like green leafy vegetables because that's where potassium is. Orange juice should be encouraged. You know what I'm saying? Things that are high in potassium, avocado, you get it. Calcium and vitamin D. Anytime a person takes steroids, they could easily have brittle bones. This patient is at high risk for fractures. And again, I just love this packet. You know, I love all the packets I use, but I love this one especially because look, he's got a cast on his leg. He's got a cane. I mean, he's really at risk for fractures. So there's that. So we want to pump up the calcium and the vitamin D, don't we? Yeah. All right, now, the one thing I teach my students about Cushing's and Addisons. Addisons is the opposite, Cushing's is the opposite, but in Cushing's you have an additional crazy issue. You have the fact that the women look like men and the men look like women. So here's what I mean. The women have something called hirsutism. Hirsutism. Male patterned hair growth on the body. What do I mean by male pattern? Hello, that's kind of fancy. Mustaches, beards, even hair on the chest. Like seriously, I would die. So again, mustache, beard, hair on the chest, and get this, females may lose their menstrual cycle, which A before a word means without. Amenorrhea, defined as no periods for 3 months. Amenorrhea, A before a word, means without, no periods. So the patient may, the woman may have male pattern hair growth on her face and her chest. Wherever there's hirsutism, there is usually acne. So she may have acne with the hirsutism, the amenorrhea. But I said that the men look like the women. What did I mean by that? Here we go. The man may have gynecomastia, which means, break the word apart, stay with your girl. You know, I got that PhD in vocabulary and language and all that, and education, showing that people don't always fail the test because of lack of nursing knowledge. Sometimes they fail the test because they don't have great reading comprehension or understand what the word is even saying, right? So let's think about that. Gynecomastia, what the fuck is that, right? Gyne means woman. Mastia means breast. Female breast on a man. I told you, the female looks like the man looks like the female. That's crazy. So female breast on a man. And then, can we talk for a minute? You know, your girl always got some good stories about shit I've done. Well, I'm old now, old as dirt, 60 years old. You know, I'm old. But when I was young, I used to do things, let's just say, I had a delightful time. So I used to teach aerobics at the local gym, big gym, you know, I don't know if you guys remember, Scandinavian Health Club, but that was the gym. It's been 30 years at least, okay? Well, there was this guy who looked so good. His muscles were like, ooh, baby, ooh, I think we can work with this. Well, that man with those big muscles, turns out that he was using what? Anabolic steroids to look like that, to look like he could carry me on his chest and do big things. Well, his use of those steroids was very disappointing in the bedroom. Let me just explain. I told you the man looks like the lady. So now we got boobs on the man. Let's just say when we dated for whatever time frame that was, 15 minutes, the muscles were up here and there was not a lot of muscle down there. You know why? Because steroids can cause testicular and penile atrophy. Ooh, yeah, your balls are small. Your penis isn't that big. Yeah, you got to know that, because maybe you can encourage your sons, your nephews, your little cousin, whoever the hell it is, not to be pumping up no damn steroids, because all this gonna look real good and you get them pants off. It's like, that was for free. Now, so women look like men, men look like women. Then we have an additional problem. We have the issue that blood sugar is high, and look, watch this. Cortisol increases the blood sugar but decreases the immune response. So look at this. This patient with Cushing's has slow healing wounds, because if you know anything about blood sugar, you know that infection loves sugar, and that if you have an infection in a wound, it's not going to heal very quickly. And if you know anything about steroids, you know that they decrease your immune response, putting you at risk for infection. And so because your immune response is decreased, you don't heal up very quickly. Y'all see what I'm saying? I mean, you get that. And then we may even have like stretch marks, or striae it's called, pink or purple striae or stretch marks on the body from this nonsense. Now, I told you, you was gonna have to go a little deeper with your girl today. This is a big video. It's kind of complex. Stay with me. If there is a tumor, let's do this again, on the adrenals, you get a Pheochromocytoma, right? Fun word, but what is it? Oh my God. It is the worst. Can I talk to you for a minute? Look up here. Come on, stay with your girl. You have a Pheochromocytoma triad. The triad includes symptoms that the patient feels and the very big sign that you pick up on. Remember how signs were things that I picked up on as a clinician or provider? Symptoms was the stuff the patient complained about that they could tell me was going on. Well, the number one sign, I put it as a circle inside the triangle. The number one sign is an outrageous blood pressure. It's like basically blood pressure on crack or whatever. In this case, blood pressure on steroids, right? So it's outrageous. Like I'm talking 300 over 150. It's definitely a hypertensive crisis or urgency. The patient is going to complain about a headache, palpitations, and diaphoresis. Now, the diaphoresis is real bad, like you're pouring sweat, and it's episodic. Like you might have it now, you might not have it today. I mean, later, right? So you might have it when you woke up drenched, and then you might not have it for the next few hours, and then all of a sudden you're at work and you're drenched again. Episodic diaphoresis. The patient is usually short of breath because, again, this blood pressure is outrageous. Their heart is racing, and I mean, they feel it, so there's palpitations. I mean, it's really bad. Okay, this is a nightmare, all right? Now, to figure out whether it's a tumor on the adrenals or if this is a tumor on the pituitary or whatever, the patient gets a dexamethasone suppression test. I want you to remember to write that because dexamethasone is ending in S-O-N-E, so you know it's a steroid. Dexamethasone suppression test. Push it down, right? Suppress it. So if we give this dexamethasone that we give at night and then check the cortisol in the morning, if the adrenal corticotrophic hormone, if the ACTH, adrenal corticotrophic hormone, if the pituitary has successfully decreased the ACTH, but the cortisol levels in the morning are still high, then we know it's a problem with the adrenals. We know it's a possible Pheochromocytoma or an adrenal adenoma. Something's going on with this adrenal. Like something is going on. That's how we diagnose Cushing's. Okay, y'all feel me? Again, dexamethasone suppression test. We give the patient dexamethasone at night. We check the cortisol in the morning. If it's still high, the patient has Cushing's. And then when we want to figure out if the reason for the Cushing's is a pheochromocytoma, to diagnose that requires a 24-hour urine test to check for the, here we go, catecholamines of epi and norepi in the urine. If we don't decide to do a 24-hour urine to check for the catecholamines of epinephrine and norepi in the urine, then we do a clonidine suppression test. We give the patient clonidine because clonidine is a blood pressure medication that decreases the norepinephrine. And if the norepi is still high, we know we have a pheochromocytoma. What is the treatment of a pheochromocytoma? You might remember me telling you that the adrenals were little scully caps on top of our kidneys. In fact, you may even remember that I taught you, in order to remember the anatomy, you needed to look at the word and you can see adrenals, additional renals, adrenal. Add it to the renals, add it to the kidneys, adrenals. That's because the adrenals do some of the same things that the kidneys do. So if I have a pheochromocytoma, I'm gonna do an adrenalectomy, right? Because the tumor is on the adrenals, but it's hard to get the tumor off the adrenals without just taking the adrenals. That would be an adrenalectomy. You're smart enough to know that if you took my adrenals, and this pheochromocytoma could be bilateral or unilateral, it's not usually cancer, so it's benign, it's just a tumor. But if you take my damn adrenals, an adrenalectomy, you could push me over here into Addisons, right? Yes, you got it. Okay, now we're almost done. We're almost done. It's a long video. Just get over it. If the tumor, on the other hand, is on my pituitary, yeah, that's going to require a little bit of work. You ain't taking no adrenals off. They ain't going to do nothing. So look at this, because it's already in your packet, and I want you to see it. We're talking a transphenoidal hypophysectomy off the patient, right? So look at this. I wrote it down because I know you're flipping out about the whole spelling and whatnot. A transphenoidal hypophysectomy means removal of the pituitary or a part of the pituitary by going through my nose, transphenoidal, or through the gums, top gums above my teeth, right? So removal of the tumor or the pituitary or portion of the pituitary. The pituitary, let me talk to you for a minute. If you put your finger in your nose, and don't be gross, don't do that. But if you were to put your finger through your nose and then keep on going with your finger all the way up, you would hit your pituitary, because the pituitary is this little teeny tiny thing, part of your brain, but it's in the center of your entire head. Like it's in the center, right smack dab in the center. You could get to it easily coming through your nose or even through the top lip. So this is the removal of the pituitary tumor or the pituitary or a portion of it via the nose or through the nose or top of the lip and through the gums. Now, let's not be dingy. If you done took your crazy behind and went all up in my gums and through my teeth and up my nose and everything else, you have to remember there are lots of complications that the nurse is monitoring for. The nurse has the patient on a mustache dressing. It means that she put a dressing right under the nose, and we call it a mustache dressing. On this mustache dressing, she is checking it with a dextro stick, like a D stick that we check, you know, ketones in the urine, or blood or sugar or whatever. We're checking that D stick or dextro stick. We're checking that gauze. We're taking the gauze off. We're dabbing the D stick in the gauze to see if there's any sugar, because cerebrospinal fluid has to have sugar in it. Snot doesn't, or whatever. The nose is packed as well. So if there's any leaking, we're checking for a cerebrospinal fluid leak. If there's a cerebrospinal fluid leak, because you did go to my brain and that's where my meninges are, if you did that and you went through there and you got a leak, then it would show up as positive glucose in this mustache dressing. Dextro stick, right? Positive glucose. Also, there would be something called a halo sign, which is like a ringlet or bullseye looking type of drainage on this mustache dressing with yellow around it. So that would be the halo sign with a little bit of blood in the center. So that would be the halo sign. That would tell you that not only do you have leaking cerebrospinal fluid, but one of the things I tell you is if fluid can get out, bacteria could get in, this patient is at risk for meningitis. Something else you have to monitor this patient for is polyuria. If the patient starts putting out 1,000 cc's or milliliters of urine per hour or so, 2 hours, 3, because remember people, we put out 1,500 to 2,000 milliliters in a day. This patient, if they start putting out 1,000 to 1,500 milliliters in a few hours following this surgery, this patient has diabetes insipidus, which is caused when you go up to the pituitary and you damage the brain, cause a little bit of injury, trauma, damage to the brain. You can have DI, diabetes insipidus, not mellitus, not DM, not high blood sugar. No, diabetes insipidus, yet another endocrine disorder we're going to go through. Okay. Now, because I went all up in your nose or through your gums, I have a rule. If I do any surgery within my hands, you watching my hands? Yeah, any surgery within my hands, above my chin, below my head. If you do any surgery within these hands, then you better be hoping and praying you remember ICP precautions. And it doesn't matter. It could be eye surgery. It could be nose surgery. It could be mouth, gums, throat. It could be all up in the face, brain, whatever. If you do surgery in that area of the body, then you need to think about the patient might need ICP precautions, intracranial precautions. Now, I told you before that the Oh My God packet is thebomb.com, so don't act brand new. And on page 11 is all of your select all that apply precautions. Shall you see with me? If you look in here, you're going to see bleeding, neutropenic, dysphagia, seizure, ICP, and suicidal precautions. So you see bleeding, you see neutropenic, you go down a little bit, you can see dysphagia, you can see that we're talking about ICP precautions right here. And they're long, I mean, you know, they're serious shit. And then you see the dysphagia, suicide. Okay, so I'm just gonna tell you, with this patient, they need ICP precautions. It says right here, see the Oh My God packet. And I just want to explain to you some of these like ICP pressure, intracranial pressure precautions. So think about it like this. Anything that the human body could do that increases pressure in any part of the body increases pressure in the entire body. Okay, so watch this. If I say to you, I don't want you to lift or bend, watch this. If I bend, pressure is going to go in my head. I'm actually going to even feel it when I bend. When I lift, I'm causing abdominal pressure, like lifting requires abdominal muscles and contraction. Now I'm increasing pressure other places. Then think about it like this. I can't blow my nose because that's going to increase pressure through here. I can't cough. Remember that, because this is a post-op patient. So you telling this patient to cough and deep breathe is crazy as hell. They can't cough. They can deep breathe, but if they or sneeze, that's going to be really high intracranial pressure. They don't need that. You just did brain surgery on this patient. They all need a stool softener, right? Because bearing down, doing a Valsalva increases pressure. This patient, you need to also monitor them and teach a lot, because they don't need to be brushing their teeth, because if they went through the top of the lip, they're going to disrupt those sutures. So no brushing their teeth for a couple weeks. Teach the patient that they may actually have a decreased sense of smell for the next month or so. Teach the patient that they're going to need a lifetime pituitary hormone replacement. Generally speaking, this is cortisol every day for the rest of their life, okay? Make sure that the patient knows to have a high fiber and push fluids. High fiber to prevent the constipation, push fluids to prevent the constipation, and a couple more things that you might see on your ICP precautions, just so you know. We're not gonna let this patient get cold or too hot or have a fever, because chills increase intracranial pressure. Okay, shivering increases intracranial pressure. No holding their breath when you go to turn them or move them up in bed. Like, you know, people do that. Don't hold your breath. This patient may need no footboard on the bed, and that's only because if they slide down the bed and they try to push themselves up off the footboard, the intracranial pressure can go up. Their head of the bed must be elevated, okay? Must be elevated, but not too high. 30 degrees is good. And then when turning your patient, they need to exhale. That's a big one. So instead of holding their breath while you're turning them because they're in so much pain, tell them to exhale. Okay, so I just took those right off of here. Antiemetics, mannitol, anticonvulsants, and anti-anxiolytics also help decrease intracranial pressure. Just saying. Okay, now that was a big old fancy video. I hope you got something out of it. It was a lot of shit, okay? Deuces, I'm out.